Okay, I want to welcome everybody to Pediatric Grand Rounds, those on the Zoom as well as those here. And I'm going to invite our Vice Chair for Education, Dr. Sandrain Van Schaik, to introduce our speakers and the topic for today.
Thank you, Dr. Hirsch, and welcome everybody. It's still a sparse audience here at the auditorium, but I'm sure people are going to be trickling in, and I've seen some people already on the Zoom. It's always really fun to announce people for grand rounds that are a little bit outside of my direct vision at UCSF, even though I've been here for quite a while. Because it makes me in awe of all the different types of work that are going on at our institution to advance child health. And if you wonder how we get to our speakers, it is through our fabulous Grand Rounds Planning Committee. And we just met this morning, by the way, and we're looking for more members. So if you're interested in joining the committee, please send me or Laiba a quick message. There will also be a recruitment email coming out. But we really want a diverse representation so that we can have a diverse set of topics. So today's speakers are both coming from a nursing background. Mayla Gutner is here with us today. And Lucy Tarala is present over Zoom. Myla is a public health nurse with SFDPH MCAH field nursing program, where she does home visits with pregnant people and people with infants. At UCSF, where she received her master's in nursing, she critiqued the studies the AAP uses to support their recommendation to avoid at all times sleeping with one's infant. Since then, she has been friends with Dr. McKenna, one of the world's experts on co-sleeping, and was appointed to be a PHN representative on the California SIDS Advisory Council. Lucy Tarala is a senior PHN and perinatal services coordinator with Sonoma County. She has devoted her entire career to pregnant and birthing people, and her experiences include maternal and child health, labor and delivery, and postpartum, lactation consultant to direct service supporting first-time parents as a PHN with the Nurse Family Partnership Program. She has also been directly involved in the overhaul of the traditional SIDS training program provided to home visitors annually, which has mostly focused on abstinence versus nuanced messaging. Both Myla and Lucy became passionate about this topic of co-sleeping because they slept with their infants and believe shaming patients further increases inequities in marginalized communities, and that providers should offer consistent messaging that is based on evidence-based medicine. So a really kind of interesting topic that is new to me. But I think as pediatricians, we also know what the real evidence is behind recommendations, and I'm really excited to have you here.
Thank you so much. That was a very thorough introduction, and we might repeat a little bit of it because it's in our presentation. Thank you for those who are joining on Zoom, and we are going to start with a land acknowledgement.
Hey, thank you, Mayela, and thank you everyone for being here today, and thank you for having us present today. We are honored to be here. We will begin with a land acknowledgement. The County of Sonoma, where I live, recognizes that we're on the ancestral lands of the Coast Miwok, Pomo, and Wapo, who are the original caretakers of this area. We respectfully acknowledge the indigenous peoples who have been stewarding and maintaining relationship on this land as knowledge keepers for millennia.
And I acknowledge that here in San Francisco, we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula.
We also acknowledge that the United States was built off of the exploited labor of kidnapped African people. Much of what we know of this country today, including its culture, economic growth, and the development throughout history and across time, has been made possible by the labor of enslaved Africans and their ascendants, who suffered the horror of transatlantic trafficking of their people, chattel slavery, and Jim Crow.
So we were already introduced, but I'll repeat some of it. I'm a mother, public health nurse with the San Francisco Department of Public Health Maternal Child Adolescent Health Field Nursing Program, where I do home visits with pregnant people and people with newborns. This is my son, he's almost 21, and my daughter. And yes, I did breast sleep with them. That is, sleep with them and breastfeed at the same time.
And I am Lucy Lugo Turala, and I am a public health nurse for the Sonoma County's MCAH department, and I am the perinatal services coordinator. And I'm the mother of 2 boys whom I breastfed and breast slept with.
Today's presentation is titled Changing Narrative and Policy, Bringing Evidence-Based Practice to Infant Sleep and Destigmatizing Bedsharing. Breastfeeding is associated with bedsharing, and bedsharing promotes breastfeeding, and yet the message has been to avoid at all times sleeping with your infant. Providing a non-judgmental harm reduction approach to infant sleep for all families with newborns, including how to reduce the risks associated with bedsharing, promotes equity, access, and inclusion to marginalized groups. Lucy and I have been very busy since October of last year when we did a presentation at our first ever conference. This presentation that you're going to see today has been adapted from that one. That conference was a lactation justice equity summit with the goal of pinpointing the structural and institutional saboteurs of lactation and to establish innovative strategies to overcome them so that families can meet their infant feeding goals. Our presentation was titled The Anti-Bed Sharing Campaign and the Sabotage of Lactation in Marginalized Communities. So you're gonna see some of those concepts throughout this presentation. Since then, we have also submitted and presented a poster at the California Breastfeeding Coalition's conference and will present at the Association of Maternal Child Health Programs in April. So please email one of us if you would like a copy of this presentation or the posters.
Infants are a historically marginalized group because they do not have the power to advocate for their needs. Black and Indigenous infants of color are even more marginalized due to the historic trauma of racism and economic and social injustice, and these effects on health outcomes. The American Academy of Pediatrics has based their claim that bed sharing is a risk factor for SIDS on studies with too many biases. Sudden infant death syndrome is highest among Black and Indigenous babies in the United States, and there is evidence that safe sleep campaigns have been targeted towards these communities. Using a harm reduction, trauma-informed approach to bed sharing will support these marginalized groups in making an informed decision about where their infants sleep and supporting their breastfeeding efforts.
So these are the objectives today: to get an update on highlighted changes in the new AAP infant sleep policy that support a harm reduction model, learn about the biases in the studies that the AAP uses to support their recommendation to avoid sleeping with an infant, learn about past and current safe sleep campaigns in the US and how they have targeted marginalized people, understand the risks associated with bed sharing and how to reduce those risks, and learn how a harm reduction approach for safer bed sharing supports individuals from historically marginalized groups. Okay, so I'm gonna be primarily speaking during the first part of this presentation, and I wanna just share how I came here. When I had my son 20 years ago, my mother gave me a book called The Continuum Concept, which guided how I raised my son as an infant, including my choice to sleep with him and breastfeed. This book was written by a white woman who went to South America to observe the people indigenous to the land. The continuum concept is the idea that in order to achieve optimal physical, mental, and emotional development, human beings, especially babies, require the kind of experience to which our species adapted during the long process of our evolution. And this is a quote from that book. When I went to nursing school at UCSF 7 years after my son was born, I was pretty shocked to learn that the recommendation was never to sleep with your infant. I was like, where is this coming from? It worked so well for me and it made sense. I also learned in nursing school that evidence-based practice is the integration of patient preferences and values, clinical expertise, and best research evidence. Since we learned how to critique studies in the master's nursing program, I decided to closely critique the studies the AAP cite to support their recommendation not to sleep with your newborn. I did my final paper on this topic in 2013, so it's been over 10 years, and recommended a harm reduction approach, which I have been using in my practice ever since. And this is just the title page of that paper. And yes, I sent my paper to Dr. McKenna, one of the world's leading experts on co-sleeping, and he said my critique was one of the best he had read. And just this September said, quote, "The paper is as good and even more relevant now than when you first showed me." And why would he say that? I think because the AAP still uses the same studies in the 2022 policy statement as they did in 2011. So this is our first and second time meeting. In the second photo, there's 2 other public health nurses who came along with me. We had the chance to meet his wife. By the way, he is in San Francisco. He's retired. So, and in this photo, this is of May of last year with the support of my boss and other people at SFDPH. We brought him to speak at General Hospital. So this is my conflict of interest, if there's any. Okay, and this is, I basically copied from the AAP's website their top 10 donors. So I just want to point this out that the formula companies, the 2 major ones for Enfamil, Similac, are in that top 10 donor list. I think it's really important to understand history. I read this book called The Big Letdown: How Medicine, Big Business, and Feminism Undermine Breastfeeding. I read this book just before going to the Lactation Summit, and it turns out the author was there presenting as well, so I got to meet her. But she speaks about, quote, the unholy alliance between formula companies and pediatricians, especially in the early 1900s. You guys are all pediatricians, so forgive me, but I mean, if you haven't read the book, please do. I do encourage you to do it. Okay, so I'm going to begin by highlighting the changes in the new AAP sleep recommendations that I think support harm reduction model. So why is there this focus on the American Academy of Pediatrics? In my experience as a public health nurse in the system, we have to follow them. Okay, so this is why I'm focusing on them. There's also the Academy of Breastfeeding Medicine, which came out with a protocol for bed sharing and breastfeeding in 2019. Which Lucy will speak about later. And I'm hoping that, little by little will be supported at work to integrate this protocol as well. Okay. So one of the most important changes in the 2022 policy statement is this one. The AAP now recognizes it is a choice, and that as providers, we should understand and respect this choice. Still, again, they cannot recommend bed sharing under any circumstance, and this is where they differ greatly from the ABM protocol. And the AAP does not recognize, for many, it is not a choice. As a public health nurse in San Francisco, I see 5 people in a small bedroom. There's just no room for even a bassinet. So for a lot of people, it's not a choice. These are some other important additions to the AAP policy statement. How does racism impact SIDS and breastfeeding outcomes? We already know they do. To tell a person not to sleep with their infant based on their race would amount to perpetuating racism. Okay, so these are the details. This is not the fun stuff, but I think it's important. When I did my paper in 2013, I was specifically looking at the statement, bed sharing, to avoid at all times bed sharing when the infant is younger than 3 months, regardless of whether the parents are smokers or not. So the AAP states there are specific circumstances that have been shown to substantially increase the risk of SIDS or unintentional injury or death while bed sharing, and these should be avoided at all times. And this is the factor I focused on, and I critiqued the studies they used to support this specific recommendation. Since 2011, the AAP has moved away from the avoid at all times language and instead speak of factors that increase the risk, the magnitude of risk. So this is a visual of the change over time of this one factor. And as you will see soon, the studies are the same that they use. And I guess my question is, why include breastfeeding when in the studies, breastfeeding is not even a variable? It's inconsistent. And in one of the studies, breastfeeding is defined as initiation at birth. Breastfed babies behave and sleep differently than formula-fed babies in that they wake frequently to feed, and even having a baby in crib next to bed often doesn't work for the breastfeeding diet. I tried it. McKenna gave me the arms reach. Have you guys heard of the arms reach? Okay, you put it next to your bed, and I tried to put my baby in there and I could not sleep. So, it just didn't work for me, personally. But as you can see here in 2016, this recommendation, it increased to 4 months. And then it included breastfed babies, even though the studies were the same. Okay, so I just want to point that out. And that breastfeeding wasn't a consistent variable. Okay, so this is what a bias is. I think there's different definitions of biases. This is the one I'm choosing: a systematic distortion of statistical results due to a factor not allowed in their derivation. And these are the biases. So they were primarily done in Europe among white populations, mostly done in the 1990s. And there were key missing or inconsistent variables. Like I said, breastfeeding was not a variable in all the studies. They did not include anything about racism, mental health, domestic violence. There was a little bit of substance use, but that wasn't consistent. I mean, all in all, not much was said about toxic stress. And toxic stress can impact how we show up in the world, how we show up with our infants. And this is small. Oh no, you guys can see that pretty well. But that's okay, the box is right there. But basically this shows that the same studies from 2011 have been used throughout each policy statement. The last study at the bottom, Carpenter, which was used in 2016 and 2022, is actually a meta-analysis and of the earlier studies. Okay. I would also like to point out some more changes over the 3 policy statements. A-level recommendations are based on strength of research. Here we see that in 2011, breastfeeding was 9th on the list of the A-level recommendations and vague. And by 2022, it is 3rd on the list and more specific as to its protective effect against SIDS. My question is, on what basis does the AAP recommend infants sleep separately and ideally for at least 6 months? I don't know. And some of the questions I ask, I'm wondering. So if you guys have answers. Okay. So here the AAP in their 2022 policy statement clearly states how important breastfeeding is to the reduction of SIDS. Well, actually, they don't use breastfeeding as the term. They say human milk. And a lot of benefits are conferred through the physical action of breastfeeding. And actually, just the other day, I saw that there were some responses to the policy statement, one by Melissa Bartik, James McKenna, and Michael Young, and they actually bring up this point that the recommendation for human milk feeding rather than breastfeeding is of particular concern. These entities are not equivalent. And then Miguel Menendez, on behalf of the Spanish Breastfeeding Association, states, we disagree with Moon, Carlin, and Hand when they state that bed sharing should be avoided in all cases. Bed sharing is associated with longer periods of breastfeeding, and without other risk factors, current evidence does not support affirming an increased risk for sleep-related infant deaths. So I encourage you to read those responses as well. And I think you guys all know about this hierarchy, but I'm still going to put it up here. This is the hierarchy of strength of research. At the top of the systematic reviews and meta-analysis, which hold the strongest strength. The studies the AAP cite are from case control studies. A case control, A case control study is a type of observational study in which 2 existing groups differing in outcome are identified and compared on the basis of some supposed causal attribute. So the AAP policy statement is considered expert opinion. So a big question I have is, why are we beholden to one set of experts over another? And this is a flyer that was shared at a SIDS council meeting. in the introduction, it was said that I am one of the public health nursing representatives on the California SIDS Advisory Council. During the pandemic, we were disaster relief workers, and I was doing night shift in the isolation and quarantine hotels. And I was like, what am I going to do with my time? Everyone's asleep. So I found that there was a vacant position, and I just really feel like the two communities, we need to bridge them. And so that was my attempt, and I'm still working at it. But this is a flyer. It says, children must sleep alone in a crib. And I'm like, where is this coming from? This is from, I don't know what the evidence is behind this. So I just want to share this with you. And lastly, I want to share some of our national health objectives, also known as Healthy People 2030. As you can see here, there is the objective to increase the proportion of infants who are breastfed at 1 year old, and this has seen little or no detectable change. The objective to increase the proportion of infants who are put to sleep in a safe sleep environment, and they don't define safe sleep environment, is in developmental status because it doesn't have reliable baseline data. I reached out recently to the US Department of Health and Human Services to find out more about this. A public health advisor responded and said that a developmental objective can't be recategorized as a core objective until it meets the core requirements. Have valid, reliable, nationally representative data, including baseline data from no earlier than 2015, and data for at least 3 time periods throughout the decade. So it is imperative to destigmatize bed sharing so data is reliable and statistics are not skewed. We need current local, state, and national-wide data. And thank you so much. And I'm going to pass it on to you, Lucy.
Thank you, Mayela. We can go to the next slide. Yes. Now we will go through and share some examples of how safe sleep campaigns have negatively impact marginalized groups. Okay, next slide. Here are 2 posters that were publicized in response to an increase in infant deaths, SIDS, in these cities. The poster on the left was posted in South Bend, Indiana in 2018. The racial demographics are 58% white and 25% Black. And to the right is a Black baby's image in a poster posted in Milwaukee in 2011, stating that a parent sleeping with their baby is just as dangerous as having a baby sleep with a sharp knife next to them. To be fair, there is a picture that also has a white baby with a similar message. The question is, who was the intended audience for these posters? Where were these posters placed? What neighborhoods? Were these posters seen in white, wealthy neighborhoods? Would the poster on the left seem to also suggest that bed sharing is likened to child abuse? Just some questions as we go through this. Wanted to share this. This is from Motherload, a New York Times blog that wrote this in response to the Milwaukee poster. A campaign against bed sharing. And the Milwaukee poster is the one with the baby with the knife next to them. Parents rightly point out that it will take more than public service ads to reduce Milwaukee's infant mortality rate in one city zip code. People are going to sleep with their infants, they argue. Better to educate parents on how to do it safely than to use scare tactics to dissuade them from something that, depending on your point of view, is affirmatively beneficial or at the very least inevitable. And the vilifying of bed sharing in the ads may prevent people from admitting that they sleep with their infants and talking about the best practices, thus causing more harm than good. Providing everyone education on the needs of infants and ways to reduce risks associated with bed sharing and learning from families about their environments and how they protect their baby is equity. All providers providing accurate and consistent messaging on how to reduce risks associated with bed sharing that has solid evidence behind it is access. There is so much to be done in our workplaces, communities, and on the state level to get to a place where a harm reduction approach is fully accepted. As we move forward, at the forefront of all that is done, we should ask, How do we involve the most marginalized and ensure their stories and voices are heard? So what does safe bed sharing look like? So these are the known hazards to bed sharing or co-sleeping. Most of you may know, of course, all of these. And we wanted to put not breastfeeding and chest feeding at the top because as we know, it is protective of SIDS. There's prone sleeping, pillows, blankets, other siblings, pets in the adult bed, exposure to smoke, adults who have consumed alcohol or drugs, or even certain medications, soft surface, couch or recliner chair sharing, which we want to distinguish from bed sharing. Okay, next slide. So here, you may have seen this. This is the C-curve position. This is the natural position most breastfeeding parents fall into, but it is a position that is accepted as one of the safest positions for bed sharing, as per the Academy of Breastfeeding Medicine protocol, which I will discuss in a minute. So it is the adoption of the C position is with the infant's head across from the adult's breast, adult's legs and arms curled around the infant on their back away from the pillow. And it is the optimal safe sleeping position. Here's another image of the same. And as you can see, the adult's arms are protecting the child from going up into the pillow, and the legs around the infant are protecting the child from sinking down away from the C curve position, and is, of course, the perfect position and proximity for breastfeeding. And babies often fall back to sleep in this position versus ending up prone. Okay, next slide. Here is the Academy of Breastfeeding Medicine protocol number 6. Hopefully, most of you have heard of this protocol, and if not, you will know more about it after this presentation. And I invite you to continue to research it on your own. Overall, the research conducted to date on bed sharing and breastfeeding indicates that nighttime proximity facilitates breastfeeding duration and exclusivity. Discussions about safe bed sharing should be incorporated into guidelines for pregnancy and postnatal care. Existing evidence does not support the conclusion that bed sharing among breastfeeding infants, i.e. breast sleeping, causes sudden infant death syndrome in the absence of known hazards, like the one we just discussed. So wanted to also point out that there are safe sleep messaging videos outside of the US. Here is one, for example, from the Lullaby Trust in the UK. There's also one from India that I've found in my research. In the interest of time, I will skip showing this here, but we will include it in our slides and our resources that we can send after this. Next slide. Here is another example of guidance from Australia, also acknowledging bed sharing and sharing tips for how to do it safely and above. And it then lists the factors that would render bed sharing unsafe, which is what we've discussed already. Yeah, all we're asking is acknowledging that this actually happens. This flyer, I'm not sure if you're familiar with it, but this is from La Leche League. And it's one of the few flyers that we have in the US that addresses bed sharing, that asks the parent to look at the 7 factors and to confirm that those are there before every sleep. Of course, no smoking, sober adults, breastfeeding, healthy baby, baby on back, no sweat, and safe surface. Okay, thanks. You can go to the next slide. This handout is by the Academy of Breastfeeding Medicine, and it's a handout for parents. It's also in Spanish, and it discusses how bed sharing and breastfeeding, and how to make your bed safe. And then at the bottom, it says, be safe even when not bed sharing. I feel like it's a great resource for parents. Okay, next slide. I wanted to point this out. This is from a project in our research. We found this that was done by nursing students in Oregon. This is the image on the left is the front cover of a safe bed sharing booklet for home visitors, which is it was made to guide and stimulate a discussion with the families that they visit. This project was presented by nursing students in Oregon in 2022. It is quite detailed and helpful, and a helpful tool for home visitors to have a conversation with their clients. However, it doesn't seem like it was adopted to be used by the public health department there yet. And I want to point out the one page on the right that says, even if you don't plan to bed share, creating a safe environment can prevent accidents. Because we all know, I mean, from my experience, that even if you have all the plans to not bed share, it can still happen, and it's better to have a safe plan in place. This is another page from that booklet, and it just shows that same couple and how they are also, that she's still in the C position, and the child is away from the pillow or any blankets, and the recommendation of using a tightly fitted sheet, one pillow, a small pillow, or even no pillows for the parents, a thin blanket, or each person has their own blanket. They can also wear warmer clothing so that there's no need for a blanket. And that in any case, as I did with my own children, is that we have any blankets or sheets would be under the child so that there's no risk of them being covered by it. And do not use rails or bumpers. Okay, next slide. So this is the MIHA data snapshot. This is maternal infant health assessment data that is done in California. In other states, it's called PRAMS. So this, unfortunately, is the most recent that we can get. We usually get these when they're pretty late. So this is 2016 to 2018. And these surveys are only a snapshot. They're only sent out to only a small segment of the population in each county. We see that infants are placed, we see that infants are placed on their back the majority of the time. However, bed sharing happens at least 37% of the time. And these are the people who are brave enough to respond honestly, as this act, as we all know, is so often stigmatized and filled with guilt and shame. And in the PRAMS CDC data in 2015, over half of the respondents, 61.4%, from 14 states reported bed sharing with their infant. And 38.5% from 13 states and New York City reported using any soft bedding, most commonly bumper pads and thick blankets. So bed sharing is happening whether we choose to address it or not. And even with the AAP's abstinence-only messaging back then, bed sharing still occurred. Then I want to bring your attention to how lactation was also negatively impacted. Here we see the strong intention to breastfeed before birth at 97.5% and 82.5% before birth. Then what actually took place was very different. 1 month, any breastfeeding is at 95%, which can also include formula feeding. And that number falls to 84.7% at 3 months after delivery. Below that, exclusive breastfeeding at 1 month has a dramatic drop from intention to 65.6% of actual exclusive breastfeeding. And at 3 months, it continues to drop to 53.7%. Then to the right is the racial and ethnicity makeup of this county, with Hispanic 42%, Black 1.7%, and those born outside of US at 21%, and speaks non-English language at home at 24%. Okay, next slide. I wanted to share this cartoon that my colleague who co-designed our new SIDS training that we do here in Sonoma County, she included in our training. The cartoon has the header, "Expert medical advice makes you abandon reality." This is an example of how well-intended messaging can fall flat, be disingenuous, disrespectful. Like any medical health information, safe sleep information has to be individualized and acknowledge where families are coming from, what their lived experience is, and meet them where they are. We should never just tell someone to do this and expect them to just magically do it. The reality is that infants sleep in many different locations and environments, including in bed with their parents or siblings, or in a car seat, in a crib with stuffed animals or blankets. We want you to keep in mind that how families sleep is deeply personal, shaped by current circumstances, family and cultural histories, practices, and may change from day to day. We think all families should be provided with information that will help them make the choices about their infant sleep environment that feels safest for them. We also think that this education should be provided early, during pregnancy if possible, and often so families and offered often so families feel equipped to make informed decisions for themselves. In the next few slides, as we wrap up, you will see examples of sleeping environments you may or may not ever know about from your patients. They will want to tell you what they think you expect to hear. And please feel free to raise your hand and ask questions or make comments as we go through some of these images. So this one, for example, these are very common scenarios that we see in the home. So Mayela, as she said, she's currently a public health nurse, home visitor, and I was one for over 7 years. And this is a very typical thing to see cribs full of blankets, diapers, stuffed animals, and they would tell me, especially when I was a newer nurse, they would say, "Of course, I put my baby in the crib every night," but we know that that's not often true, and that it's usually filled with diapers and blankets. Okay, sorry, you can go to the next one. A birthing parent may also be in this type of living situation as well. Does anyone have any comments about how you might address a patient living in this situation?
I think they can't speak. They're going to do question and answer on the Q&A at the end.
That's right. Yeah, no one's, I guess, out there either. Okay, no problem.
No, you guys are here. There's actually a good group here now.
Oh, okay, good.
Yeah.
Okay. But of course, anyone in the audience there can feel free to comment. Yeah, this might not be something some may not feel comfortable addressing this. But we invite you to reflect on these images and really think about your clients, your patients, and really listen to your client and where they're at and build that trusting relationship. This is another example. And question is like, how might you help this patient come up with ideas on how to make this sleep environment safer? If they are not necessarily able to share details about their environment, let's say in a visit with you that might be too short to address this, could an image like this be a good teaching tool for you during their clinic visit? Like showing them these images, which is what the project with the Oregon nurses that I mentioned, they have that included in their booklet, these images. And they ask the client, how can we make this environment safer? For instance, in this situation here, there may be no space for a portable crib. Think about how you would have the conversation with a family who has their baby in a bed like this. Could we make it safer? Can we give them all the tools and all the information in a non-judgmental, trauma-informed way? Lastly, many clients may have to couch surf at some point, and they may not share this with you. We will want this parent to know about free crib programs. For example, as we know that any couch or recliner sharing is extremely dangerous and is different than bed sharing. This is a quote from the Journal of Pediatrics. It's a commentary referring to AAP guidelines back in 2017. Such an approach focuses on the dangers associated with bed sharing and omits the discussion of how those risks might be mitigated short of eradicating the behavior. Next slide. Then they go on to say, similar to the abstinence-only approach to sex education or the just say no approach to drug use, safe sleep campaigns have endorsed a strong and unwavering abstinence position regarding the target behavior. A recent literature review that included studies from multiple countries concluded that existing research does not support an unambiguous anti-bed sharing stance. These authors highlight the need for interdisciplinary research with stronger study designs, as well as a more nuanced approach. And I'll say again, a more nuanced approach to these complex biological, physiological, and cultural issues. And I would add anthropological as well. So the time has come for all of us as caregivers to break down what has been ingrained in our training. Many already feel the black and white blaming approach that refuses to look at the historical trauma and structural inequities does not align with how we approach our clients. Other countries such as Britain, India, and Australia already have a harm reduction approach in how they disseminate information on safer sleep. We must return the power to our birthing people. We are not the experts on their lives. They are. We must not gatekeep and live our lives with our babies hypocritically. Safe bed sharing or co-sleeping should not be judged simply as harmful and to be avoided at all times. And we need policy to change to demonstrate that. However, we cannot do it alone. We are tasked to design a robust, family-centered, trauma-informed, and culturally sensitive approach to SIDS and safe sleep messaging, while we also work to increase breast, chest feeding awareness as a fundamental public health priority. And above all, community engagement. Research and policy must be informed by the community we are aiming to reach. Thank you so much for your time and attention to this topic. And below are our emails if you would like to reach us.
Thank you, Lucy.
Thank you.
Thanks for sharing all this. I'm curious if you, in some of the higher risk situations that, like the photographs where you said you may not avoid things, if you have any recommendations around some of the wearable baby monitors, some of the newer technologies that, you know, there's a lot of us who have some of the concerns about the reliability of those devices, but there may be some benefit in certain situations.
Yeah, Lucy, can you hear the question also?
Yes, I did hear it.
Okay.
Yeah, those monitors are problematic. I feel it seems like we're not sure how reliable they are, and we would worry that parents would have a false sense of security with them.
I mean, I don't ever recommend monitors because first of all, people don't have the resources. Usually when you say high risk, like, I'm not sure if you have an idea of a high risk situation you're thinking of.
Well, I guess I was thinking, you know, as you showed pictures of some of the sleeping scenarios that you might advise or intervene, if there are situations in which you don't have an easy solution, do you ever suggest something?
Yeah, no, not with monitors. That's never come up in my 10 years as a public health nurse as a topic with the families. Yeah.
Yeah, more than anything, it would be a conversation. And I wouldn't necessarily see their bed. Of course, there are risk factors of what they have there in their bed, but I would feel like after a conversation and letting them guide how they would like to approach it and giving them all the information that risky bed situation could be changed and become much safer.
I think risky situations are working with people who have substance use disorder during pregnancy and go from the hospital to treatment programs and are still in that transition, and yet they want to breastfeed. That gets a little bit more tricky. I still give them the same information. I like to start, ideally we begin with pregnancy and we talk about, you know, we do a full assessment. This is as a public health nurse, but like what was their childhood like? What are their goals? What are their goals for the baby? What are the needs of the infant? And start there and work with them starting there. But each situation is different. I go and look at the bed. I even like sit down and see how soft it is. I look to see, does the bed move? Ideally, McKenna says this, the mattress should be like away from the wall in the middle of the floor, but that's really not realistic in a lot of places. So I see, is there gaps between the mattress and the wall? How can we fill those gaps? Is your partner sleeping in bed with you? Sometimes partners are willing to sleep separately in the first few months so that the birthing parent and the baby can have their own space in the bed. So it all depends on the family. right? And then just looking at the bed and how, as Lucy said, how we can make it less dangerous. Yeah, that's a great question. And we don't advise whether you're breastfeeding or formula feeding differently. It's the same messaging. With the families I've worked with who exclusively formula feed, oftentimes the baby is in the crib. There's not really, it's not really quote unquote an issue. But I have had families who exclusively formula feed and bed share. And that is a little bit more risky. However, I still provide the same harm reduction messaging and ask them like, so are you a deep sleeper? Like, are you able to wake when your baby stirs? And they say, yes, I'm not a deep sleeper. I'm still able to wake. And so we go over the bed environment again. There's sometimes people who have a combination of formula, breastfeed, combination of crib, bed, where they put the baby to sleep in the crib. And then in the middle of the night, they bring the baby into the bed. And it's very diverse. But I've had families who exclusively formula feed and bed share. Yeah.
Great presentation. You guys, I don't know if I missed this when you mentioned it, but has there been like solid data from other countries or countries in terms of incidence being lower in those countries or cultures? And then I was just wondering if there has been data, have you noticed any like patterns as to maybe in certain cultures there's just more people taking care of the baby or other factors?
The question, Lucy, I've been
Sorry.
talking a lot. Did you
No,
hear that? Or
I didn't
it's not
hear
that
the full question, but I heard like if there's solid data on SIDS in other
in
countries.
other countries. Yeah, and I could talk. So I haven't read all the studies. It was a long time ago that I went to school, and this was my little thing I did that just like I can't get it out of me, right? So what I do know, the little I know, is that SIDS is higher in the US, SIDS is higher in Australia, in Japan, it's not as high, and in Asian countries, it's not as high, and they still bed share. There's also less smoking there, higher breastfeeding rates. I could ask McKenna this and get back to you. He is good. He knows all this stuff. I think breastfeeding has a lot to do with it. I also think having extended family around is very important. I think here in the United States, a lot of people don't have that extended family to provide the birthing parent with that support. The SIDS coordinator in San Francisco has a great idea of that, birthing parents should have a doula that comes in during this critical period to provide support. And, I think it's a great idea. We would just need the funds, but, and traditionally that was the grandmother or another extended family member who provided that support. And I think that exists.
Oh, sorry, didn't mean to cut you off, but also the issue that we don't have paid family leave, appropriate paid family leave in this country. So parents are having to go back to work as soon as possible, which can cause so much stress and can break down the breastfeeding dyad, and then they have to supplement or feel forced that they have to supplement because they can't keep up with the demands. But I was
Lucy,
also going to
that's a
mention
really good
Japan.
point.
Yeah, I was also going to bring up Japan, that they have one of the lowest, I think, SIDS rates, and they typically bed share.
Yeah.
Yeah. It's more just bringing acknowledging the reality that it's happening. I find that like in public health, there's always like, you have to give them one message and that's it, because there can't be nuance, because then they won't hear it, and that we're not giving the trust and the ownership to our families to be able to take all the information and make the best decision for themselves. But also that breaks down that relationship if they're going to feel like, well, they're going to tell me I shouldn't be doing it, so I'm just not going to tell them. And then that breakdown of communication happens. And it's better to say, hey, some families bed share, and so what are your thoughts on it? And can I show you some images of what that could look like, and what's probably not safe, but what could be safer? Just so that way it can bring up and help them feel comfortable that someone understands that this is a reality, maybe a reality for them.
think from that perspective, your analogy with the sex abstinence really resonates with me. I was born and raised in the Netherlands, and when I moved to the United States, I was actually shocked. These campaigns targeting teenagers that said, don't have sex, and I'm like, the fuck with that. Right? I mean, it's gonna happen, and they're just not gonna tell you about it, and then they'll, oops, they're pregnant or have an STD or whatever. And then I think there's a lot of data to suggest that it is much more effective to educate people on how to have sex safely than to tell them that they should just not have sex. It feels to me, especially with the reality that you're showing for a lot of these families, not even being able to have their child in a separate bed.
Yeah. So if you guys have any high-risk parents here or people, you know, who could use extra support, please refer to public health nurses. We're here in
Yes.
San Francisco.
Yes,
Oh,
good
you do?
plug.
Okay. Okay.
I'm also thinking we should, I don't know who's in the audience from nursing, but we should think about how we actually send our own families home from nurseries and things like that, with a much more balanced and nuanced message. So thank you. I don't know if there's another question here.
Sorry.
Yeah.
So this also comes up in the hospital setting, that we have a sort of complex policy that makes it hard for families to co-sleep, and I think for the younger infants. And there's a lot of reasons for that related to our hospital beds and our nurses having access to the baby. Curious if you know any health systems that do allow co-sleeping and or models that do it well
In the hospital?
in a hospital setting, because it's very disruptive for parents who co-sleep at home to come in, and then when their child is sick, and say, now is the time you're not allowed to be in bed with your child.
Right. No, I don't. I mean, imagine if there was a hospital where we had safe beds where they could do that, right? But the hospital bed is dangerous. It is dangerous to sleep in there with a baby. And I don't know. I could also ask McKenna that question. I was gonna say that I gave birth to my daughter here 6 years ago, and they cut my bladder. And so I was way out of it. And, you know, I was discharged home with Roxy, oxycodone. And I slept with her. And I remember I took an oxy and I was like, and I did pass out a little bit too much. And I was like, oh, cannot believe I did that. And I wish someone had said to me, a nurse, like, look, you had a major surgery. You're in pain. Be very careful. Like, remind me. It's about reminders. It's about saying, look, when you're on this medication, you're going to heavily sleep, you know? And luckily nothing happened. But it's not about saying don't do it, but like the reality of it, and to be very careful. How can you be careful? Remember to put your baby, if you're going to be on this medication, put her in the crib next to you, or is there a partner who could help you? Anyway. Huh?
Just providing, good anticipatory guidance.
Right.
Empowering them to make the best decisions. I think that's particularly relevant for people with, for instance, use tobacco. Really, it's incumbent upon us. My county hospital, where social circumstances that you described, or we do try to provide. We also are attentive to the things that are truly more risky, like sleeping maybe on a couch and sleeping with somebody that's helpful. Then we're not.
Right. Yeah, and it's safer to actually lie down in bed and breastfeed than be tired and sitting up in a couch or chair. Yeah. Thank you, guys.
Thank you. This was great. I definitely learned a lot, as I knew, but I learned more than I thought I was going to learn, because I also really appreciate your attention to this idea that the AAP guidelines are not necessarily something that we should say, oh, the universe of pediatrics said this is what we should do, and therefore we should do it. So critically looking at guidelines, I think it's another good lesson to remind yourself. So thank you. This was great.
Thank you.
Thank you.
Thank you for joining us from Sonoma.
Oh, sure.
Yeah.
Glad I could be
Lucy.
here. I appreciate it. Right.